So I'd like to thank Dr. Fitzpatrick for that lovely introduction, and also, of course, the Society of Translational Oncology. These are my relevant disclosures. Please take a moment to review them. So I was actually fortunate enough to give the inaugural Progress and Promise talk for STO back in 2011. And when I did that, this is what my slide looked like. I think it's particularly striking when you look at it because my topic was AR-targeted therapy, or androgen receptor-targeted therapy, and there were no androgen receptor-targeted therapies available for our patients. So my talk at that time was full of a lot of progress, but we had yet to fulfill the promise to our patients of actually bringing AR-targeted therapy into the clinic. In 2014, this is what it looks like, and so in just 3 years, the scoreboard here, or the dashboard, is crowded with available options for our patients, and there's certainly more to come. But for the purposes of today, I'm going to focus on the AR-targeted therapies, Abiraterone and Enzalutamide. I'm going to briefly go through those and then walk through some of the newer agents that are in development and future directions for these drugs. And my hope is that in doing so today, that I can set the stage for my colleagues to delve a little deeper into the biologic mechanisms of resistance and progression in ways that we're trying to understand individual or precision medicine a little bit better. So we knew for a long time that the androgen receptor was important in the clinic because we could cycle patients through subsequent lines of AR therapy and they would often respond. In addition, when patients started to progress on androgen receptor targeted therapy, their PSA would rise, indicating that AR was still active because PSA is an AR responsive gene. So when you look at this slide here, what you can see is that in the non-castrate state, the androgen receptor is expressed, but actually as patients have progression through the non-castrate state into castration-resistant disease, there's actually AR overexpression that sensitizes tumors to low levels of androgen. So in fact, the androgen receptor is an even better target in castration-resistant disease, potentially, than it is in the earlier disease states. We've also learned over the past decade that the androgen antagonists, such as bicalutamide, are weak and reversible inhibitors, but importantly, when the androgen receptor is overexpressed in the castration-resistant state, some of the mechanisms that lend to resistance are involved with agonist activity. So the androgen receptor can actually mutate and become promiscuous, meaning that it can bind to other ligands. And one of those ligands can be bicalutamide, and the bicalutamide can actually convert. Oh, thanks. The bicalutamide can actually convert from an antagonist into an agonist. And so the drug that we were giving the patients to try and control the disease can actually stimulate the disease in advanced stages. So this is a cartoon, if you will, of the therapeutic targets of the AR signaling pathway, and I'm just going to walk you through this. So what you're looking at here is in the cytoplasm, the androgen receptor is bound to an HSP90 chaperone protein, and the HSP90 protein protects the androgen receptor from degradation. When the androgen receptor binds to ligand, and in this case the ligand is the potent form of testosterone, dihydrotestosterone, the androgen receptor moves into the nucleus of the cell and initiates transcription of AR target genes that are involved in cell growth and survival. So there are a number of different pathways that you can target in the androgen receptor signaling pathway to try and affect a response for patients, and we've looked at a lot of them. So we've looked at HDAC inhibitors and AR-mRNA antagonists, HSP90 inhibitors, PI3K pathway inhibitors, but by far the most successful interventions that we've used to date are drugs such as Abiraterone, which inhibit the adrenal and intratumoral synthesis of androgens, and also Enzalutamide, which is a potent AR antagonist that prevents or impairs translocation of the androgen receptor into the nucleus. So I'm first going to talk about Abiraterone acetate, and just to quickly review the mechanism of action. Abiraterone acetate inhibits the CYP17 family. When it inhibits C1720 lyase, it downregulates androgen precursors and ultimately the potent ligand dihydrotestosterone. It also inhibits 17-alpha hydroxylase, and when it inhibits 17-alpha hydroxylase, it results in downregulation of cortisol. When the brain senses the low cortisol levels, it actually feeds back and upregulates ACTH, and that can cause a secondary mineralocorticoid syndrome that can be manifest with fluid retention, hypertension, and hypokalemia. So to mitigate this toxicity or this potential toxicity of secondary mineralocorticoid syndrome, most of the trials using Abiraterone today use a low dose of glucocorticoid, typically prednisone. So this was really a landmark study. It was approved, I think, 24 hours before the very first Progress and Promise lecture series, and it was certainly a time for rejoicing. This was really the first study to show that an androgen receptor targeted agent could actually improve survival in castration-resistant prostate cancer, and more specifically, in patients with very advanced disease who had already received docetaxel. It was proof of principle beyond a shadow of a doubt that the androgen receptor is in fact relevant in castration-resistant disease, and it changed the landscape of how we look at this cancer and how we treat this cancer forever. So this is the Kaplan-Meier survival curve for the 301 study, which was the Abiraterone after chemotherapy study. And what's remarkable about this to me is that there were 1,200 patients that were accrued to this study, over 140 sites in 13 separate countries, and this was accrued in just little over a year. And it speaks to the need for these kinds of therapies for our patients who had advanced disease and the lack of available therapies for them, because remember, the patients were randomized 2-to-1, so there was a proportion of patients who actually were taking the risk of receiving placebo plus prednisone. So these patients were randomized to abiraterone acetate plus prednisone versus placebo plus prednisone, and you can see that the overall survival benefit was 14.8 months for the abiraterone arm versus 10.9 months for the placebo arm, with a hazard ratio of 0.46 and a p-value of less than 0.0001, which reduced the risk of death by 35% in this population who otherwise had no viable treatment options. The drug was also very well tolerated, as we expected. The adverse events were consistent with the mechanism of action of abiraterone, which is mineralocorticoid excess. So based on the very promising activity in metastatic castration-resistant prostate cancer following chemotherapy and the very favorable toxicity profile, this drug was moved earlier into the disease state for patients who had not yet received chemotherapy. And so this is what study 302 looked like. It was for metastatic castration-resistant prostate cancers who were minimally symptomatic or asymptomatic and had not yet received chemotherapy. One of the novel endpoints of this trial was not just looking at overall survival, but also looking at radiographic progression-free survival. And we heard a little bit about that earlier today from some of our speakers, including a nice review by Michael Morris, which explained why overall survival may not be the best endpoint for patients in the earlier disease states. As we develop more drugs that are improving survival, the bar gets raised higher and higher, and so we may be not able to approve these drugs anymore for patients based on a survival benefit, even though they may benefit or may have activity. And so one of the co-primary endpoints in this study was radiographic progression-free survival. Abiraterone in this study did in fact double the time to radiographic progression-free survival. You can see here the median time to radiographic progression-free survival was 16.5 months for abiraterone and 8.3 months for prednisone, and this represents the interim analysis 3 data at 56% of events. The abiraterone arm also favored overall survival. The median overall survival for abiraterone was 35.3 months, and for prednisone was 30.1 months. This had a hazard ratio of 0.79 and a p-value of 0.0151, but importantly, this did not cross the pre-specified significance value, which was a p-value of 0.0035. This is a really important slide. These are secondary endpoints for this trial, but I think when you're looking at a patient population that's not yet had chemotherapy and are minimally symptomatic or asymptomatic, of course all patients want overall survival to be improved, but we really lose sight sometimes of the secondary endpoints or the quality of life endpoints that mean so much to our patients in the clinic. And so you can see here that secondary endpoints, meaningful secondary endpoints, like time to opiate use for cancer-related pain, time to chemotherapy initiation, time to deterioration of performance status, all of these were improved favoring the abiraterone arm, and they were statistically significant. So this is what the list of approved agents with an overall survival benefit looks like as of 2014. You can see that abiraterone was approved in 2011 based on a survival benefit in patients who had already received chemotherapy, and then achieved expanded approval in 2013 for metastatic castration-resistant prostate cancer prior to chemotherapy. Now I'm going to shift gears a little bit and talk about enzalutamide. So enzalutamide is a second-generation AR antagonist. It's previously known as MDV-3100. And the way it works is the androgen receptor in the cytoplasm, again, is in its unbound, unliganded state, is bound to HSP90. When it binds to ligand, it undergoes a transformational change, and this transformational complex then translocates into the nucleus. The way enzalutamide works, which is distinct from bicalutamide, is it has a greater affinity for binding to the androgen receptor, and it impairs nuclear import such that it also impairs DNA binding and coactivator recruitment. So this is the AFFIRM trial, another study looking at the post-chemotherapy metastatic castration-resistant prostate cancer population. Again, this study also accrued very quickly. It was approximately 1,200 patients, and you can see that the hazard ratio in this study was 0.63, which translated to a 37% reduction in the risk of death for these patients. Importantly, this enzalutamide study did not require glucocorticoids for enrollment. Glucocorticoids, again, are not necessary for AR antagonists, but some patients were already on prednisone because they were cycling off chemotherapy with docetaxel. And Howard Scher and Vivek Arora have brought to some interesting data regarding glucocorticoid receptors and their interaction with AR, which we're still evaluating. In terms of adverse events of special interest, fatigue was the most common adverse event in this study for enzalutamide, but really the adverse events were well matched between the treatment groups. I think the seizure risk got a lot of press, if you will, and it was brought up when it was presented at ASCO, but the incidence was very low, and when you look at the actual patients who had seizure on this study, they were patients who either had brain metastases or potentially were on drugs that could lower the seizure threshold. That being said, we know that seizure potential is a risk for AR antagonists as a class. It's not specific to enzalutamide. We've seen it in the clinic with another anti-androgen called BMS 641988, and it appears that the way that this class of AR antagonists initiate seizure activity is through an off-target mechanism of GABA-A inhibition, and that the higher the brain drug concentrations of the AR antagonist, the higher the risk of seizure. As a result, it's not surprising that the more novel agents that are coming online are paying a lot of attention to the seizure potential in preclinical models. This is an example of another second-generation AR antagonist that works similarly to enzalutamide. And you can see here in preclinical modeling that at the same dose of enzalutamide, or MDV-3100, there are lower brain and plasma concentrations of this compound, and that suggests a higher therapeutic index for this drug. So we actually did the first-in-man phase 1 study of ARN-509 at Memorial Sloan Kettering, and we cycled patients through doses ranging from 30 milligrams all the way up to 480 milligrams. Shown here are the PSA kinetics for this trial. You can see the maximum PSA decline during study on top and the maximum PSA decline at 12 weeks on the bottom. These are waterfall plots for PSA. Each individual line represents the PSA of an individual patient. And you can see that across dose levels, there was activity as indicated by a decline in PSA, and this was independent of dose level and also prior chemotherapy as denoted in gold. The safety profile was equally favorable. There was only one dose-limiting toxicity. It was grade 3 abdominal pain. And notably, this was in a patient who had previously had abdominal surgery and was having difficulty tolerating taking all the pills at one time. So when we broke the pills into BID dosing, he was able to tolerate it much better. So one of the really exciting things at Memorial is through a collaboration with Steve Larson, Michael Morris, Howard Scher, Joe Fox, we've been able to look at FDHT PET imaging, and I'm sure Dr. Morris will talk about this a little more, but just to briefly review, fluorinated dihydrotestosterone is a way that we can look at AR binding in real time as a pharmacodynamic marker of anti-tumor effect or of drug mechanism. And so what you're looking at here on the top is a patient who had an FDHT PET imaging study done prior to treatment with ARN-509. And then 4 weeks later, he had a repeat study done. And you can see that this area that binds to the fluorinated dihydrotestosterone up top is no longer hot, or the SUV has decreased. And that's likely because the ARN-509 is now bound to the androgen receptor and displacing the FDHT from binding. So this is a really exciting way to see that the drug is actually hitting the target. So we use this data, the FDHT data, combined with preclinical modeling to pick the optimal biologic dose for this drug. So rather than just dose escalate until we hit toxicity and risk the potential of raising the plasma and brain levels of this drug, we actually looked at the FDHT decline that you can see here, which showed a maximal decline at 240 milligrams in SUV. And we looked at real-time PK modeling comparing to our preclinical mouse dosing, and the optimal biologic dose based on that was also 240 milligrams. So this is how we optimized the dose for this study, and it was quite gratifying to see that these two modeling efforts were in sync. So we moved on to a phase 2 study using 240 milligrams as the phase 2 dose. This was done in castration-resistant prostate cancer patients, and this time it was broken into 3 separate groups. The first group was castration-resistant prostate cancer patients who had no metastases, and that was the M0 group. The next group were patients with castration-resistant prostate cancer who had metastatic disease but had not yet received chemotherapy. And then the third group were a group of patients who had already received Abiraterone, and we were trying to see what it looked like to give a second-generation AR antagonist following at least 6 months of Abiraterone. The primary endpoint of this study was PSA response at 12 weeks. So here you can see the kinetics for these phase 2 cohorts. For patients with castration-resistant prostate cancer, whether they had metastatic disease or not, the PSA response rate was between 80 and 90%. But interestingly here, this was the first prospective study to look at a second-generation AR antagonist following abiraterone acetate. And we had elected to have patients on abiraterone acetate for at least 6 months in order to enroll on study, trying to look at cross-resistance between these two drugs and to remove patients who had primary resistance to abiraterone who would be off abiraterone treatment much earlier to better understand if we could cycle patients through subsequent treatments with AR-targeted therapy. And what you can see here is that 24% of patients met the PSA response of 50% or greater decline at 12 weeks. But really, there was probably about 50% of patients who had some degree of PSA decline, indicating that there is a subset of patients who are on abiraterone who will then go on to receive second-generation AR antagonists or other AR-targeted therapies, and that these are the patients we need to figure out and discern who will and will not respond to these drugs. So I really love this slide. This is a slide of PSA waterfall curves, and I dare anybody here to tell me which curve is abiraterone, which curve is MDV-3100 or enzalutamide, and which curve is ARN-509. I don't think you can do it because they look very, very similar. And I think that the similarity between these waterfall plots suggests biologic predictors of sensitivity and resistance to AR-targeted therapies may be similar, regardless of the mechanism of action of the drug. Another way of looking at this is we looked at patients on about approximately 90 patients who received enzalutamide, and we looked at their patterns of PSA and radiographic progression-free survival response. And you can see here there appear to be 3 classes of patients getting these drugs. So there's a class of patients who very clearly respond to treatment with enzalutamide. They have a very rapid and durable decline in PSA, and when they do start to progress, we would consider this kind of progression to be acquired resistance over time. Then there's another population of patients who clearly are not responding at all to abiraterone. They have a very rapid rise in PSA, and these non-responders likely have primary resistance to this type of therapy. And then there's this intermediate group of patients where they have an initial decline from baseline in PSA, and then over time their PSA begins to drift. And those patients probably also have a different mechanism of response and resistance to these kinds of drugs. And I think the challenge for us moving forward in the field is to better understand what's driving these different types of responses so that we can personalize medicine and treat the patients accordingly. So some of the possible mechanisms of resistance to these kinds of drugs: increased AR copy number in response to androgen depletion by adrenal lyase inhibitors. I should also mention that there can be increased enzymes, adrenal tumor enzymes, that can be in response to these adrenal lyase inhibitors. Upregulation of these enzymes can also occur when you use AR antagonists that impair nuclear translocation. And so some of the ways that we're trying to look at this and combat this, if you will, is by combining CYP17 and AR antagonists together. So this is the Alliance trial. Dr. Morris will be leading this trial. It's looking at enzalutamide in Arm A versus enzalutamide plus abiraterone and prednisone in Arm B. The primary endpoint for this is overall survival, and there are many, many biologic correlates that they plan to look at to help us better understand how combination therapy can change the face of treatment for our patients. Another possible mechanism of resistance to AR-targeted therapy is through ligand-independent transactivation of androgen receptor via alternative signal transduction pathways. So one pathway that we're particularly interested at Memorial Sloan Kettering is the combination of AR and PI3K inhibitors. So we know that AR and PI3K pathways are the two most frequently altered pathways in prostate cancer. And more recently, Brett Carver at the HOP program at Memorial Sloan Kettering and others have shown that there appears to be crosstalk between these two pathways, or reciprocal feedback, such that if you inhibit one pathway, you actually activate the other, and vice versa. And this is a way of cells sort of helping themselves to survive in the setting of antagonism. So we've designed a phase 1b study of a second-generation AR antagonist to block AR activity, along with a PI3K pathway inhibitor, namely Everolimus, in patients with metastatic castration-resistant prostate cancer who have already received Abiraterone. The goal of this study is to see if dual inhibition of both pathways can actually overcome primary resistance and delay the time to acquired resistance for these patients. And there's actually precedent for this kind of model in breast cancer patients. The Bolero-2 trial actually resulted in the approval of this combination for patients with breast cancer. You can see at the bottom of the slide that the improvement in progression-free survival was 7.8 months versus 3.2 months, favoring a combination of exemestane plus everolimus. But perhaps also very important is that the secondary endpoint of response was 12.6%, favoring the combination arm versus only 1.7% for exemestane alone. And so we're very excited about this combination as a possible future therapy for our patients who are developing resistance to Abiraterone. So I don't know if I'm going to get asked back for 2017, but just in case, I've prepared my slide. So this is, again, bringing you back to the slide that I opened with. These are the approved treatments that we have right now in 2014 for the treatment of metastatic castration-resistant prostate cancer. Future directions are certainly going to be using these drugs in earlier disease states, and there are already some trials ongoing, phase 3 studies looking at AR-targeted therapy in non-metastatic castration-resistant prostate cancer. And Mary Ellen Taplin's done a lot of work looking in the neoadjuvant setting as well with very promising results. Sequencing. So this is very important too. Do you give enzalutamide, then abiraterone, then enzalutamide, docetaxel, sipuleucel T? I mean, the potential sequences are really quite numerous, and so we're trying to better understand how to sequence these drugs as well and prevent cross-resistance. Combinations. So we talked a little bit about that today, using AR and CYP17 inhibitors, or using AR and PI3K inhibitors, or really AR and any of these drugs over here on the right in combination to treat disease to see if we can improve outcomes. Novel agents, as always, we didn't even have a chance today to talk about drugs that are on the horizon, like cabozantinib, for example, and a number of other ones that are looking very promising. But really, I think that we can all agree that prostate cancer is a heterogeneous disease, and the only way we're going to be able to really move this field forward right now is to look at biomarkers to individualize our therapy. It's a critical unmet need for patients in need, and we're making great strides in that. And so with that, I'm going to end my talk and hand it over to my colleagues to talk about biomarkers. Thank you.